Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about vitiligo. Definition: vitiligo is an acquired autoimmune condition in which functional melanocytes disappear from affected skin. The cause is unknown. Lesions clinically appear as totally white, non-scaling, sharply demarcated macules. Vitiligo, the pigmented macules in the common periorificial area distribution. Incidence: the reported incidence of vitiligo varies with the population studied, but it is thought that about 1 in 100 people are affected worldwide. In the past, higher incidence rates were thought to occur in dark-skinned individuals, but actually this reflected the observation that vitiligo is more noticeable in more darkly pigmented skin. It is now known to occur equally across all ethnicity, genders, and age. The peak incidence is in the 10 to 30 year age group. History: vitiligo is usually asymptomatic. It begins as one or more small spots that gradually enlarge the affected areas, sunburn easily. Most patients seek the medical help because of cosmetic and cultural concerns. Physical examination: the primary lesion is a white macule that is usually totally depigmented. This feature can be appreciated best by was light examination, which accentuates the pigment contrast and may also make evident previously undetected areas in lightly pigmented skin. The skin otherwise is normal, specifically no scale is present. Macules of vitiligo are round or oval. They may become confluent as they enlarge, resulting in a large macule with an irregular border that remains sharply demarcated from their surrounding normal skin. In vitiligo, the pigmentation is complete. This is best seen by was light examination. Vitiligo lesions appear bright white under UV light. As we can see here, we can see bright white lesions under UV light in the area affected with vitiligo. Vitiligo can affect any area of the skin and mucous membranes, but the most common areas are the extensor bony surfaces like backs of the hands, elbows, and knees, and the periorificial areas around the mouth, eyes, rectum, and genitalia. In vitiligo, the pigmented macules in acral distribution are difficult to treat. Involvement of hair areas often results in depigmentation of their hair. In vitiligo, hair turns white with follicular involvement. Vitiligo often presents in a symmetric distribution, underscoring the autoimmune nature of the condition. In vitiligo, a symmetric distribution underscores the autoimmune nature of the condition. Differential diagnosis: vitiligo is more often over-diagnosed than under-diagnosed. Tinea-versicolor, psoriasis alba, and post-inflammatory hypopigmentation are differential diagnosis of vitiligo. Less often, vitiligo is misdiagnosed as one of these conditions. However, vitiligo is the only one of the common white spot disease that results in total depigmentation. In addition, it can be differentiated clinically from tinea-versicolor and psoriasis alba by the absence of scale. Finally, vitiligo lies flush with the skin, so note the absence of elevation to also aid in differentiation. Laboratory and biopsy. The laboratory is not helpful for diagnosing vitiligo. Serum thyroid test, blood glucose or hemoglobin A1C, and complete blood count with differential may be ordered to screen for occasionally associated thyroid disease, diabetes, and the rarely associated pernicious anemia. Biopsy is not usually necessary. If performed, it will show an absence of melanocytes, sometimes with accompanying inflammation. Vitiligo: in epidermis, we have complete absence of pigment and melanocytes, while dermis is normal. Therapy. There is no cure for vitiligo. Emotional support is a top priority. The goal of therapy is to manage the cosmetic disfigurement caused by the disease. Therapy for repigmentation is prolonged and the results are often suboptimal. For limited disease, the topical genus kinase inhibitor like ruxolitinib 1.5% cream is the first treatment approved by the US Food and Drug Administration or FDA for repigmentation in patients aged 12 years and older and is applied twice daily. Topical high-potency steroids, example clobetasol, have been successful in some patients. To avoid skin atrophy, it is better to use the treatment at intervals, example alternating twice daily for 1 week and then 1 week off. Topical macrolides like prototopic or Elidel are popular for use in facial and genital vitiligo. These agents do not cause skin atrophy. Facial and truncal vitiligo respond more favorably to medical therapy than vitiligo located on the extremities. For rapidly progressing vitiligo, a short course of systemic corticosteroids can be considered. However, dosing guidelines and length of treatment have not been delineated, and this treatment should be used thoughtfully, weighing the risk and benefits. For extensive involvement, the administration of UV light is recommended. The current treatment for choice is narrowband UVB. The current treatment of choice is narrowband UVB, which can be used in adults, children, and pregnant patients. The excimer laser, which emits light at 308 nanometer, which is close to narrowband UVB wavelength, is another form of phototherapy with the added advantage of delivering laser light to affected skin only, usually done twice weekly for up to 6 months. Another phototherapy which is reserved for the most severe and recalcitrant cases is the administration of a sorolin medication, 3-methylsorolin or 8-methoxysorolin, followed by exposure to long-wave ultraviolet A light or PUVA. The sorolins can be administered topically or systemically, especially for widespread disease. Some 100 or more treatments are often required to achieve the result, which in some patients is complete repigmentation, in others only partial pigmentation occurs, and in the remainder treatment fails. Surgical therapies have also been employed occasionally. Normally, pigmented skin is harvested by suction blisters or punch biopsies and transplanted into vitiliginous areas. Experimental transplantation of cultured melanocytes has also been reported. An alternative is to cover the lesions with a cosmetic that is blended to match the color of the patient's normal skin. The products most frequently used for this are Covermark and Dermablend. In selected patients with extensive disease, the best cosmetic result may be obtained by depigmenting the remaining normal skin. Topical application of 20% monobenzyl either or hydroquinone or benaquine is used for this, but the patient must be aware that the resulting depigmentation is irreversible and treatment can take up to a year. This option is FDA approved for depigmentation. The conclusion of therapy for vitiligo: initial therapy include emotional support and covering cosmetics with Covermark or Dermablend, and topicals like ruxolitinib 1.5% cream applied twice daily, clobetasol cream twice daily alternating 1 week on and off, topical macrolides twice daily, especially facial and genital vitiligo, and narrowband UVB or 308 nanometer excimer laser. And alternatives include PUVA, topical or systemic, and surgical like epidermal grafting or autologous mini grafting, and depigmentation of normal skin in recalcitrant widespread disease. Course and complications. The course of vitiligo is unpredictable. In most patients, it is chronic and often slowly progressive, but can be rapid in others. Occasionally, it involves the total body surface, resulting in complete depigmentation. Spontaneous repigmentation occurs in a minority of patients, but is usually incomplete. Repigmentation begins around the hair follicles, so it appears as freckles that become confluent as they enlarge. Approximately 40% of patients will relapse within the first year after successful repigmentation. Associated systemic disorders occur in some patients with vitiligo. Thyroid abnormalities, including Graves' disease and thyroiditis, are the most common, with frequency ranging from 1% to 30%. Depending on the series, Addison disease, pernicious anemia, diabetes mellitus, and alopecia areata are other autoimmune disorders uncommonly found in association with vitiligo. Experiments indicate polymorphisms located in the gene NALP1, which is involved in the regulation of innate immune responses, play a role in these other disease susceptibilities in a subset of patients with vitiligo. Pathogenesis: melanocytes are absent in vitiligo. The mechanism for their disappearance is not known, but multiple theories exist. Four proposed theories, not necessarily mutually exclusive, are highlighted. First theory, autoimmune. Investigators have proposed that melanocytes are destroyed by an immune mechanism. Antibodies against melanocyte antigens have been detected in patients with vitiligo. This may be the primary cause of the disease, or they may occur secondary to any initial injury to the melanocytes that results in the production of antigens with subsequent antibody formation. Cellular immune mechanisms have also been implicated in melanocyte destruction, such as activated cytotoxic CD8 plus T lymphocytes and numerous cytokines. Second theory, oxidative stress. This theory posits that oxidative stress promotes vitiligo by the activation of the innate immune response. It is thought that reactive oxygen species act as signals which activate pattern recognition receptors, which then trigger inflammation, leading to the recruitment of cells in the innate immune system, such as macrophage and natural killer cells, with the end result being the destruction of melanocytes. And the third theory is neural. This theory proposes that a neurochemical mediator is responsible for the destruction of the melanocytes. Some animal models have clear-cut neural control mechanisms for pigment formation. And the fourth theory is self-destruction. The intermediate compounds in melanin synthesis are cytotoxic when present in sufficient concentrations. The self-destruction theory holds that in vitiligo, these compounds accumulate in melanocytes and eventually destroy them. Clinical case: a 28-year-old woman presents with several painless white patches on her hands and around her mouth that have gradually increased in size over the past year. She denies itching or scaling. Her past medical history includes autoimmune thyroid disease. On examination, there are well-defined depigmented macules on the dorsal surfaces of her hands and around her lips. The hair within the patches is also white, so no scaling or inflammation is seen. Whose lab examination accentuates the depigmentation? Which of the following is the most likely diagnosis? A. Tinea versicolor. B. Pityriasis alba. C. Vitiligo. D. Post-inflammatory hypopigmentation. And E. Leprosy. The correct answer, according to our explanation, is vitiligo. Explanation: vitiligo is an autoimmune condition leading to loss of melanocytes and resulting in depigmented macules and patches. Commonly affects the face, hands, genital area, and body folds. Frequently associated with other autoimmune diseases, example thyroiditis, diabetes mellitus type 1, and pernicious anemia. No scaling, no sensory loss, and sharp borders help distinguish it from other causes. Differential points: tinea versicolor is fine scaling caused by malassezia, shows yellow-green fluorescence on wood lamp. And Pityriasis alba is mild hypopigmentation with fine scaling and mainly in children is seen. Post-inflammatory hypopigmentation is history. The patient has usually history of preceding rash or trauma. And leprosy, the patient has hypopigmented patch with loss of sensation. Okay, this was explanation about vitiligo. Thank you for your attention.